Thank you for invitation to this webinar today and the opportunity to present the individual ventilation strategies and considerations from Zürich. In the next 20 minutes, I will describe you how and why we performed individual ventilations in COVID-19 patients. I have no relevant conflicts of interests. First of all, for better understanding, I would like to mention that this figure from Shear et al. It was published in BJA a few weeks ago in 2020. I would like to mention different stages from coronavirus disease. The disease begins with an incubation phase, followed from rearidemia, and mostly COVID-19 patients present asymptomatically or with mild symptoms. Only a small percentage for severe cases progressing towards organ dysfunction is of importance, especially in the phase 2 and 3. You see it here. 2 and 3. You know from the paper from Gattinoni, there's the type L phenotype and the H phenotype. With pulmonary manifestations under the underlying endothelitis and the inflammatory and coagulatory dysregulation lead to severe course that requires admissions at the intensive care unit. Possible intensive care support in these phases lies in the supportive application of oxygen. You see it here, and invasive or non-invasive ventilation or high flow therapy. And in the very severe cases, you need rescue therapies from INO or at least an ECMO are applied. Marini and Gattinoni describe it in their letters that hypoxemia and subsequent increased inspiratory effort lead to a vicious cycle. The pathophysiological changes caused by a virus caused hypoxemia. You see it here in this cycle. The viral disease leads to pulmonary dysfunction, recruitment of human cells, either by direct viral infection of the endothelium or immune-mediated, and can result in widespread endotheliitis and consequently alveolar dysfunction. This leads to a virus inspiratory effort in this part, with the consequence of the increased minute volume and more negative interthoracic pressure with little notion and deep dyspnea. The increased negative interthoracic pressure and the high tidal volumes lead to edema due to inflammation and increased endothelial and further alveolar permeability. This leads to dependent atelectasis and increased volume of breathing. Submission caused increased volutrauma, barotrauma, atelect trauma, and biotrauma, and aggravate the initial insults. What is known as a PCL, you see it here in the middle of this circle. And the ventilator-induced lung injury. As a result, the vessel stretch increased and leads to an increased edema, which get more power concentration of part of our lungs and makes the baby lung shrinkage, and worsening the hypoxemia, and the cycle was closed. In our experience, vicious cycles can be reduced or broken by the right intervention at the right time. For example, recompensation with high flow, perhaps with non-invasive ventilation, or with the right time point from intubation and mechanical ventilation in this part. This leads to a better outcome by allowing presence to recompensate from the L-type to the age type. Okay. In addition, to be correct, intensive care interventions, oxygen application, high flow therapy, non-invasive ventilation, intubation, and invasive ventilation. So following points are of particular importance. The right PEEP management to prevent de-recruitment, attention in obese patients or patients with decreased chest wall elastance, control of oxygen and ventilation with permissive targets, prevent mechanical overpowered, and avoid increased effort and work of breathing. You see it here. So precise evaluation of measured static compliance as a surrogate parameter from transpulmonary pressure. So continuous evaluation of mechanical power, recruitment, de-recruitment, chest wall elastance, and uncontrolled spontaneous breathing with the required continuous adjustments of ventilation settings show an important and individualization ventilation. So all measurements severe to present ventilator-induced lung injury. The aim is to ventilate the lung as physiologically as possible and to prevent second damage in the lung to the lung by ventilation. Based on the literature ARDS, the current valid stages of lung protection ventilation have been applied. Currently, the literature, it is still unclear where the best PEEP is. However, we will learn new concepts for this from my colleague in the following sessions. In our experience, we initially applied to evaluated PEEP levels, especially in the L type, and notice over the course of time that especially in the early phase, PEEP has been limited between 8 to 10 millibar or measured, assessed by means of PEEP titration or an esophageal probe. In the H type phase, higher PEEP levels are often to be applied. Based on the current literature, plateau pressure has been limited to the maximum of 30 centimeter water. If possible, measurement is inspiration hold. We predominantly used Intellivent-ASV in all COVID-19 patients and achieved a tidal volume of around 7 milliliter per kilogram ideal body weight. Compared to the lung-safe study, this is current certainly acceptable, especially in the lung, in the L-type phase, more liberal management of tidal volume, especially up to 8. You see it in this lung-safe study. In severe ARDS patients, they get tidals around 7.5, should be applied with regard to mechanical power and frequency compensation. According to the current findings, the focus should be more on driving pressure. You see it in this publication from Ahmad from the New England Journal. I think everybody knows this publication from New England Journal. The multivariate relative risk of death in the hospital increased by driving pressure higher than 15 centimeter of water. Based on this data, this maximum limit should be applied to your patients. Breathing rate was kept as low as possible, optimal below 25 per minute, especially because the breathing frequency has considerable influence on the mechanical power. There was no fixed PaCO2 target in our patient. We target a pH higher than 7.25. All these individual targets values can be well summarized in the concept of mechanical power. There we get a target below 17 joules per minute. Based on the publication from Gattinoni with mechanical power, you see it in the in this formula. With the OTIS and the MEET formula, much of this work of inspiration is covered by the Intellivent-ASV 1.1, especially because the breathing frequency has a considerable influence on the mechanical power. This combined with the simplified mechanical power formula can be used to continuous evaluation. Now, from theory to daily clinical practice, how individualized ventilation was performed in Zürich. Now to the questions why we used Intellivent-ASV in critical ill COVID-19 patient. We used Intellivent-ASV in all critical ill COVID-19 patients if resources were available. Background from this decision is the continuous adaptation of the ventilation and oxygenation settings and the continuous change of the conditions based on the collected surrogate parameters SpO2 and end-tidal CO2 values. The validity of these continuous values are regularly validated by invasive measurements in arterial blood gas analysis. Furthermore, the ventilation is based on a minimal work of breathing with the OTIS formula and the MEET formula. This is calculated individually, breath by breath. Another reason is precise pre-settings of oxygen and ventilation targets make it easier to use and primary work even for inexperienced employees. And the last one, the continuous machine adjustment with the presetting minimized the work and the time at the mechanical ventilator. And you can use the time for other things what you have to do to your COVID-19 patients. For understand Intellivent-ASV is not intelligent automatic ventilation. It also required continuous supervision and controls. Intellivent-ASV in critical ill patient can only be successful as a part of a lung protective bundle. Shortings in the Intellivent-ASV are measured of dynamic parameters. These can be adjusted by manual measurements of the inspiratory and expiratory hold maneuvers. Also, the ARDS network PEEP table overestimated the PEEP, especially in the L-type COVID-19 patient, and required a limitation. An evaluation of the recruitability of the implementation of the requirement maneuvers can significantly improve the conditions of the lungs. Reduce inspiration effort during spontaneous breathing during peracute phase should be avoided. If in doubt, we performed the transpulmonary pressure measurement in Zürich to get a better overall impression and to better understand to the difficult breathing situation. Now to our ICU concepts. Our ICU concept is based on the other therapies currently discussed in the literature. I repeat it, our standard ventilation mode is Intellivent-ASV in all COVID-19 patients. Prone position was performed in patients with PF ratio below 200 millimeter of mercury, ideally early in the course of the diseases. Patients in the early phase receive a lung at rest strategy with PF ratio below 150 millimeter of mercury. Here, neuromuscular blockade is considered early. High flow therapy, you see it here in yellow, is performed with intermittent close monitoring of the inspiratory effort. There is a risk of missing the right time point for lung protective ventilation, and perhaps you increase the risk of patients have induced lung injury. The use of NIF, we you see it in red, was forbidden in our ICU in moderate to severe de novo hypoxemic respiratory failure, has also been consistently associated with a high failure rates of increased mortality, particularly when associated with tidal volumes greater than 5 milliliter per kilogram ideal body weight. Also, we use ECMO, and inhalated NO is performed as a rescue therapy if the indication is given. But the most important thing is to bring all the concepts into your team is teaching. Our ICU philosophy is teaching. All these measures only work in the context of an expanded teaching concept. For this purpose, we trained super users. This was the key role in teaching at the ICU and the consultant to conduct on a daily training bedside, and as a part of hands-on training, you see it here, and an SOP for ventilation was prepared and made available to the all staff. Difficult cases, you see it here, were discussed with the help from an online seminar with consultant and with colleagues from the clinical concept group Hamilton Medical. At this point, many thanks to Bernard Schmidt. What we teach additionally, we use a lot of more teaching units in this part. We teach way of measuring inspiratory effort, especially to prevent PESILI. We teach clinical signs of increased inspiratory effort. We teach the P0.1 value as in my opinion, a little bit bad parameter to the increased respiratory pressure, and we increase modern concept of a pressure muscle index, who was published from Belani in 2019 to evaluate the inspiratory effort in spontaneous breathing patients. Also, we evaluated and taught the PEEP tool to looks for recruitment and de-recruitment in all the patients. Concept of mechanical power was taught, and compliant measurements in controlled and spontaneous breathing patients. You see it here. Volumetric capnography, and at least in unclear cases, or in a situation you want do you want to know more about your patient, we use the pressure measurements. In summary, this teaching bundle could again significantly enhance the knowledge and the quality of ventilation. Unfortunately, in the first wave, we were not able to ventilate all patients with Intellivent-ASV from our concept due to the lack of capacity of ventilators with Intellivent-ASV. The team had to be deployed in 2 different intensive care units. You see it, we call this unit Süd 2B, and we call this unit BUF. This was the old trauma unit we reactivated for this pandemic patients. The team had to be deployed in these 2 units with 2 different ventilators, Hamilton S1 and Draeger V500. A special training and refresher course with Draeger 500 was performed. This gave us the idea to prospective compare the 2 intensive care subunits in 2 different ventilation modes. To specific consideration was due to the high number from patient intensive care units worldwide and overburdened, resulting in a lack of resources and expertise. Our thesis was closed loop ventilation as a fully automation and optimized ventilation mode could be associated with a higher degree of lung protective ventilation while reducing the number of manual mechanical ventilator setting adjustments in the ICU during COVID-19 pandemic. First of all, in this closed loop versus conventional mechanical ventilation, COVID-19 ARDS, overall 47 COVID-19 patients from the first wave assessed to eligibility. We have to exclude 7 patients because they were ventilated with high flow and non-invasive ventilations. All invasive ventilated patients were randomized to either conventional ventilation group or closed loop ventilation group. 17 patients were assigned to the conventional and 23 patients to the closed loop ventilation. All ventilation data were evaluated minute by minute. Overall, 728 ventilation days were monitored minute by minute on lung prospective ventilation. Criteria of lung protection were peak pressure below 30 centimeters of water, tidal volume below 8 kilogram per ideal body weight, and driving pressure below 15 centimeters of water and mechanical power below 17 joules per minute. All patients had severe ARDS. You see it here in the PF ratio around about, the median of PF ratio was 92. This and the subscores overall was 36. The mortality rate of all this patient was very low. The mortality rate overall the first wave was 20%. There was no ventilator related deaths. Okay, now you see the results. You see overall closed loop ventilation was superior in lung protective ventilations. So the reason for this was particularly superior in terms of respiratory rates. You see it in this picture. You see all the parameters which we have measured for lung protective ventilation. You see here peak pressure in the first week. And you see here the PEEP, you see the respiratory rate, and you see the tidal volume, the driving pressure, and the mechanical power. And the blue line is the conventional ventilation group, and the red line is the closed loop ventilation group. And you see it especially in the respiratory rate. Was superior in lung protective ventilation in the closed loop ventilation. And another example was the driving pressure was significantly increased in the closed loop ventilation. And last one was the mechanical power was significantly increased too. If you see this slide, then you see in blue one, you see the conventional group, and the red one is the closed loop ventilation. You see this spider diagram to 100% of time, and 0% of time is in the middle here. And you see the values for lung protective ventilation. You see the mechanical power, the driving pressure, the peak pressure, the tidal volume below 8 milliliter, and the tidal volume below 6 milliliter, and the SpO2 rate above 88%. Overall, especially in the first week of the COVID ARDS, closed loop was associated with a 179% more time on lung protective ventilation compared to the conventional ventilation. Based on the results of our study, we demonstrate the successfully of closed loop ventilation in achieving lung protective ventilation when compared to conventional group. Now you see these boxes, the blue and the red boxes. The blue one is the conventional group and the red one was the closed loop. Already compared to the lung safe study, and a new study was published in Lancet Respiratory Medicine by ONET, also time rating intensity of mechanical ventilation and mortality in patients with acute respiratory failure. Already in the control group, you see it here of the conventional ventilation. We could show that the superiority of our nurses and doctors. You see it to the mechanical power. We have 15% to ONET, always 49.5%, and in the lung safe study, we have 93% over time. You see it here from tidal volume below 8 versus 66% overall in the lung safe study. Nevertheless, Intellivent-ASV still shows a superiority to this group, to the conventional group, especially in the parameter of peak pressure, driving pressure and mechanical pressure. Overall values between 80 and 90% from time in these times. Okay, now to the conclusion. In summary, I would like to endorse the words of Sanghilo and Gattinoni. The key rule of intensive care is to provide support, buying time for patients to heal spontaneously. And with the words from Hippocrates, primum non nocere, first do not harm. The use of an extended bundle with Intellivent-ASV for an individualized lung protective ventilation may be the key to treat severe ill COVID-19 patients. Thank you very much for your attention.